Hey, folks, if you haven't done so already, please click that subscribe button below. That'll help us grow as a show, attract better guests. Together, let's make healthcare better for everyone. Once again, click that subscribe button. We'll see you on the next one.
Get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live. Ladies and gentlemen, welcome to Broken Healthcare. My name is Ray Kober. I am your host. And joining us today is Shay Forbes, Head of Employer Solutions at Turquoise Health. Shay helps employers take control of healthcare spending by making prices transparent and actionable. At Turquoise, he's leading the charge to bring clarity to one of the most opaque industries in America. That'd be healthcare, folks. Shay, welcome to the big show.
Thanks, Ray. Excited to be here. Thanks for having me on.
Awesome. We really appreciate you being here. So tell us, insurance and the solutions in the periphery of self-funded health plans, it's an intangible. It's kind of abstract. And so help us kind of understand how you fit in at Turquoise. What exactly do you do?
Yeah, there's certainly no shortage of complexity in healthcare, as everybody knows. And Turquoise operates in a corner of healthcare that is very complex, and that's healthcare pricing. Some of the listeners in the audience may remember that there's some executive orders that came out in around 2019 that said hospitals should have to post their prices. And I think it's a very simple, very reasonable ask, but as we know, healthcare pricing can be very complex. And so as the legislation went live in 2021 with the Healthcare or Hospital Price Transparency Act, hospitals were required to post their negotiated rates via machine-readable files. So machine-readable files are these publicly available, essentially just large spreadsheets that essentially go through the price of an MRI and an X-ray and what the prices are. That is very complex. And so what we do is we take all of that data from every provider, every carrier in the country, and essentially make sense of that so that self-funded plan sponsors can make sense of who to partner with, where care should be received, and really help their members make the best choices possible when they seek care.
Yeah, and that's really important because I think what you're referring to is the passage of the CAA, right, which went into effect in January of 2021. And one of the many kind of, key bits of that legislation was price transparency. And so you would think that if healthcare weren't so dirty, you would think that that would be a great opportunity for hospitals to embrace this and say, you know what, we are going to be transparent. We're going to put our prices out there so that everyone understands what the cost of a procedure is. And the reality is today, most people aren't aware, but hospitals have something called the charge master. And the charge master is this, huge, complex, typically machine-readable file that may have over 200 different prices for the same exact procedure or CPT code, which is mind-boggling, right? Yep. And so what I'm hearing you say is that at Turquoise, your business is kind of making sense out of that gobbledygook.
Yeah, absolutely. And you hit the nail on the head. It's very complex. How things are billed, there's different modifiers that will affect what is actually reimbursed and what the rate is. As you mentioned, multiple rates for the same CPT code. And I think if you extrapolate that out across all hospitals, on the carrier side, they're also required to post things like labs, imaging, ASCs, professional groups. So by the time that you bring in every MRF, it's about 800 terabytes worth of data that is posted on a monthly basis.
I'm sorry,
that's
what's
a lot
MRF?
of data.
What's an MRF?
Machine-readable file. Yeah,
sorry.
So,
there we go.
Yeah,
we love the acronyms.
Yeah. That's the other thing about healthcare. We're really good at acronyms.
Right.
So with those machine-readable files, you're looking at about 800 terabytes worth of data on a monthly basis that is put out on publicly available links. You need a lot of computing just to be able to download that. For instance, United Healthcare posts 56,000 machine-readable files on a monthly basis. I've tried to download one file and it crashed my computer. And so it just kind of sheds a little bit of light on like how complex this data can be.
Yeah.
What we've built is this system that really synthesizes it, clears out some of the noise so that employee benefit leaders can get straight to insights and action.
That's insane. So I don't want to get too geeky for you or the audience, but when we produce a podcast, particularly an in-studio podcast, we have a multi-camera shoot. We shoot in high def. It's not uncommon between the audio and the video files to get up into like the 500 gig range, right? And if we need to upload that to the cloud, it takes time. It's like not a quick thing. So if you're talking about, like 40x that, I can't even imagine the data required. Is it cloud based? Is that a big part of the expense, would you think, at Turquoise, is being able to host and have the technology infrastructure to deal with all of that?
Yeah, absolutely. That's part of what we do is we, handle all of the backroom technical elements so that, again, when a consultant or an advisor or an employee benefits leader is looking at the data, they don't need to run SQL or in a large scale database. They can get straight to the insights and action that they need. And so that's really kind of the role that we play as a price transparency data company.
Now, are you guys then, member facing? Are you employer facing? Or is it more of a behind the scenes integration with a TPA or some other widget that then would be the interface? In other words, I guess what I'm getting at is, how does the employee or the member interface with your technology?
Yeah, it's a great question. I'll caveat that by saying that we work with all stakeholders. I handle our employer solutions department at Turquoise, but we also work with payers, providers, life sciences as well. And so kind of the use case depends on who's accessing the data, right? Some teams will have the ability to run a large scale query. And so we'll set up like a SQL database that they can go in and query the data and kind of run their own custom analysis on the back end. But we also do have tools specifically for benefit leaders that if you want to benchmark, how Cigna compares to United compares to an Anthem plan, you can actually reprice your claims within 30 to 45 minutes and see, okay, our incumbent carrier is, on par. Maybe we are okay with the status quo, or maybe they're a little bit higher and maybe we want to go out to bid and kind of evaluate our vendor partners there. So that's from a benefits leader perspective. From the member perspective, we do have some member tools where you can kind of integrate your cost sharing information, your benefits plan, and then go and search for care and understand, okay, I need an MRI. I'm going to go have this done at an imaging center versus this tier 1 hospital. And the prices are obviously going to follow there.
Yeah, I think more and more people are, becoming knowledgeable in that they understand that the cost of healthcare is typically inversely proportional with the quality metric, which is counterintuitive. It's a little tough to wrap your brain around, but often the best path to care from a quality perspective is not necessarily the big hospital system. Sometimes it is. It depends on kind of the surgeon and the specialty, but hospitals are kind of, and I'm using a broad brush here, right? They're all different, of course, but I would say that according to what I know, they don't do all things equally well. They're really good at some specialty stuff, and they do a reasonably good job maybe in some other areas, but there are also some buckets where their numbers are not the greatest. So that's one aspect of it. The other aspect of it, if you look at the main cost drivers or profit centers, I should say, for hospitals, two of the biggest are elective surgeries and major diagnostic exams. So if you're going to a major diagnostic, if you're going to a major hospital for a major diagnostic exam, you might be charging 10x for that same exact exam using the same exact technology and equipment with the same exact training, trained radiologist to read the exams. And you could find that same stuff down the street for a tenth of the cost. And so part of what I'm hearing Turquoise does is they distill this information so you know what the cost is at the hospital, you know what the cost is at the freestanding radiological clinic, and you're basically driving better informed consumers.
Yeah, absolutely. And it's funny you say that. Last night I was actually having dinner with some friends, and this friend had an MRI come up, and she was complaining about the cost of that MRI. It was $4,000, which is, a lot for a routine MRI. And so we actually pulled up Turquoise data, and had she gone to this ASC down the street, like literally across the parking lot from the hospital, it would have been about $450 there. And so I think that there's, it's my philosophy that the way that we fix healthcare is we have to get this information closer to the consumer, right? You have to get closer to, the members that we serve as benefit leaders. But that being said, in this case, like, you may not realize that you have options. A lot of times you're going to the hospital for an MRI because you were referred there by your physician. And so I think it's up to us as benefit leaders to really instill, like, there's opportunities, there's optionality with where care is received, and that just because you need this MRI or this X-ray doesn't mean that you have to go specifically to that particular place. And through benefits design, steerage, there's a lot of innovative things that employers are doing with this data to really drive value for not only the plan, but also for the member there. And you also alluded to quality too. And I think, like, the biggest challenge ahead for benefit leaders right now is driving to value. I'm very bullish on price transparency. It's obviously what I do day in, day out. That's the corner of healthcare that we kind of operate in. But ultimately, value is bridging and kind of threading the needle of cost, quality, and access, right? Is the care accessible for the member? Is it high quality? And then is the cost reasonable? Doesn't always need to be the lowest cost, but if it's high quality, we're okay sending our folks there. And I think that's really the biggest challenge that we have as benefit leaders, to kind of drive to high value care. And I'm optimistic that price transparency will play a role in that.
Well, no doubt. And it really touches on the root cause of the problem, which is healthcare's big lie, which is you can't control the cost of healthcare, which is absolute BS, right? We know that, well, you just said it. You were out to dinner with a friend, $4,000 for the major diagnostic exam, the MRI at the hospital, and your data show that right down the block, nearly 1/10 the cost, $450 for the same exact exam down, a couple hundred feet in the other direction. It's so the thinking that we're going to continue to feed the status quo and pad the coffers of the insurance carriers and, frankly, the hospitals. Like, let's just call a spade a spade. Hospitals are taxed with having to perform many functions that are loss leaders for them. They lose money in other areas of the care that they're required to dispense. But on the flip, they are making it up by overcharging in areas that are profitable for them. And that comes at the expense of the employer plan, and it comes at the expense of the member, the patient, who ultimately is footing the bill. And to your point, it's precisely what we try to do when we're working as healthcare consultants and educating employers to say, you can do something about this. And one of the things that you really can do is, particularly if you're out there with high deductible plans, and when it comes to a major diagnostic exam, maybe there's a $500 copay or more that the employee or their family member is going to be required to pay for that test. Well, maybe you design a plan so that that would be the case if they do go to the hospital system that they're referred to by their surgeon, or if we're educating them and now they know that they have a plan B, an alternative path to go to the radiological clinic down the block. And if they go there, they'll pay $0 out of pocket. They'll save themselves the out-of-pocket expense, whatever it may be. And the employer-paid plan, which is responsible for paying the claims in a self-funded arrangement, they're now saving themselves close to 90% of that bill charge. And if you rinse and repeat and you do that over and over again, well, now, golly, you may be onto something.
Yeah, absolutely. It makes me think of there's a cool experience that an employer had using price transparency data. Large metro area, they were equidistant to three major health systems. And looking at, you called out elective surgeries. They were looking at musculoskeletal surgeries. And I'll just highlight the ACL surgeries there. Because that's actually like surgery that I've had. It's why I got into healthcare, was because of a bad experience that maybe we can dive in there. But they were equidistant to these three systems. If you looked at the ACL surgery costs between the three systems, they were all high quality. They were all the same distance from the headquarters in the office building, and they were all in network. So like all things considered, they're the exact same. Hospital A is $17,000. Hospital B is $13,000. Hospital C was $7,000.
Wow.
And so what the employer did was exactly what you just described, which is, well, we want everybody to go to Hospital C for this. And so let's do $0 out of pocket. We will foot all the bill and make sure that there's no like member responsibility if they go to Hospital C. If they go to the others, they're subject to, how the plan is designed there. And I think that that's really where like benefit leaders have an opportunity to really, one, reduce trend, because we can't keep on this 8 to 10% every year, but also just fixing healthcare. There's an old quote that I love, which is, if you don't steer your members, somebody will. And so you have to set up the plan in a way that's going to steer them to high value care that bridges the gap between cost, quality, and access.
Who came up with that quote? That sounds like a good interview. So
yeah,
I've never heard that before, but that's great because it's so true. We're living in a society and a culture where even our doctors are incented to refer patients within their health system. It's called RVUs. It's one of the ways that they drive income. One, typically in a typical system, there are two ways docs are paid. One is the volume of patients that they see, which is inherently a problem because they're way overloaded and stressed. And the other thing is RVUs. So if they're referring patients within their health system, part of their compensation depends on that. And so in that case, they're steering the patient, right? And if you're doing it instead, so the doctor's motivation in that case is personal. Doctors are people just like you and I. They have overhead, they have mortgages, they have car payments, they have bills to pay, they have medical school to pay for. And so part of it, I think, is for selfish reasons. That's not to say that physicians get into medicine for that, right? It's just part of the game, though. It is part of the system. And then the hospital system that they're affiliated with is putting pressure on them to do it. So either way, whether they're doing it for selfish reasons or they're doing it because they're being pressured, that pressure exists. And so if we are educating folks and they understand, hey, if there's a path for me not to pay a penny out of pocket and the quality is the same or it's curated so that I know that the quality is high, why the hell wouldn't I do that?
Right. Yeah. The reality is most members are not as close to healthcare as you and I or I'd imagine anybody listening to this podcast is. And so if you go to 99% of the member population and say, hey, if you go to this facility and it's $0 out of pocket, there's likely that's likely where they're going to go. And I think that that's just, again, one mechanism that benefit leaders can do to drive value for their members is set up the plan in a way that drives to high value care that is also in the best interest of the member, in making sure that they're taken care of, their care is received, but that you're doing your job as a fiduciary.
So the Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket cost for healthcare. Visit benefixa.com today. No, and I think it really is important, and it makes sense, because if you look at it just commonsensically, right, you can't measure quality of a physician or a surgeon or a healthcare system. There may be Google reviews for this or Yelp reviews for this, but for Christ's sake, please don't do that. This is not the way to pick a quality physician or healthcare system. But when you have folks that you have who are medical professionals, they're MDs, they're RNs, they're data scientists that are looking at the data and they're saying, well, here's what the math says. Here's what the numbers are. And now the employee has a path to guided care as opposed to, I'm going to go have my knee done by, my golf buddy's surgeon because he had a good outcome. Or I'm going to go to have my hip done by this gal because she's the chief of the department. You could be the chief of a department and have really low quality scores, folks. I know that might be a lot for you to kind of wrap your brain around, but they're out there, and you have to. Unfortunately, this information is not public facing. It's not something that's out there that everyone has access to. But what I'm hearing you say though is part of your ecosystem, like you're on the employer front. Do you also have the opportunity for a general listener to benefit from Turquoise, or no? That's not.
Yeah. So if you go to our website, turquoise.health, we actually have a consumer-facing portal where essentially you can go in and search for care. You can go and look up, common healthcare procedures in your market. We do have a couple plans loaded in there. It won't have your member cost sharing kind of automatically loaded in there. That's for the employers that work with us directly. But you can go on our website, search for care, and look up things, like an MRI, an X-ray, other procedures there. You also mentioned something kind of interesting about quality too, and I just want to kind of touch on that. Is that, if you look at Google reviews for hospital systems, if you look at and you just filter to the negative ones, it almost always has everything to do with the billing process. None of the bad reviews come from the actual care received. A lot of the good reviews will be about the care received. But I think that's just a really good example of how everybody feels about healthcare pricing. It's so complex, so confusing that that's where the Google reviews. So I do echo that. I don't think you should choose your doctor off of a Google review. There are good quality metrics. We don't produce them, but we partner with several companies that produce provider quality metrics. And I think, again, if you bridge that cost and quality piece, that's where you're going to get true value. A Google review might skew that a little bit, just because that may not be tied to outcomes or remittances or readmissions and things like that.
Right. Do you have a sweet spot in terms of the area that you're working with employers of self-funded plans? Is it 50 and up? Is it 100 and up? Is it 500, 1,000, 5,000, 10,000? What is kind of the sweet spot of the population that you're targeting? And what can an employer expect? So an HR professional that's, listening to this, a VP of HR, CHRO, or a CFO, if they're listening or they're watching this on YouTube and they're like, this is interesting. And I'll tell you, one thing that jumps out at me, Shay, is many of the solutions that we talk about are anti-status quo, kind of anti-big insurance. I don't get the sense that that's the case with your solution. I feel like, and you correct me if I'm wrong, but I feel like your solution kind of plays nice in the sandbox with everyone, and that may be appealing to maybe a large employer that isn't quite ready for some of the more, I'm going to use advanced, for lack of a better word, cost containment strategies and solutions. Am I on the right track there, or is no?
100%. So as I mentioned, we work with large health systems, we work with the large carriers, we work with life sciences, we work with kind of everybody. And so Turquoise is very much we take a Switzerland approach to everything. Everybody uses our, yeah. We take, everybody kind of uses the data, and we feel like the data will be for the betterment of everybody, right? The ability for both sides of the negotiating table to have our data just is going to advance healthcare a little bit more. So that's like our holistic philosophy there. I will say, in terms of your question on where do we fit in, it's really any self-funded plan sponsor. So we've got consultants that leverage our data on 50 life groups that are self-funded. We also, and I would say we've got some that leverage it for very innovative, we're just going to go and grab the cash rates from the MRFs, and we're going to set up a cash pay, kind of focused plan, and do away with a traditional network. That's very aggressive. And then we've also got some that, are tied to a Buka plan, and they don't really want to expand outside of that. Their population is very dispersed, and so they need a very broad network. And so they'll leverage our data to evaluate that. Really,
does your data? I'm sorry to interrupt. Does your data also identify who accepts cash pay readily? I mean, I think any provider would accept cash, but I think some maybe are more apt to do so than others.
Yep. So on the hospital side, when hospitals post their rates, they're required to post the cash rates. For other provider types, you may not get the cash rate there, but you can use some of the commercial rates to kind of benchmark. And typically, and again, some groups are, if we present it cash, we kind of expect there to be some sort of a cash pay discount, and that's kind of the thesis there. But you will have access to cash pay data there. As far as who accepts it, we don't necessarily have insight into that, but I think most probably would, especially if you're willing to pay up front and not delay their revenue cycle by 90 to 100 days.
Gotcha. And do you have any data on what an employer can experience in terms of the efficacy of using you guys? Is there a general ballpark percentage? I know that's very tough, right? Every group is going to be different, but is there anything that the DMs who are listening to can sink their teeth into?
Yeah, it's hard to say a percentage, and I'd say mostly because the claims experience is going to change year over year. So one of the things that folks will use our data for is they'll use it to reprice claims. The way that we've evaluated networks for the past 25 years has been off of UDS, or discount off of bill charges. The way that data is kind of produced is carriers self-report that data at the zip 3 level. So you can't actually drill in and say, if I'm in New York, I can't go in and see, I want to look at NYU versus Mount Sinai versus, some other health system. Montefiore, right? I can't go in and do that. I can see at a zip 3 level, here's how the average discount is, but I can't see by claim, things like that. So the beauty of this data is you can upload your claims data, don't have to go talk to the carriers. You just go upload your claims data into Turquoise, and then I can see, okay, last 12 months, we spent $10 million with this carrier, and if those claims had all been routed through carrier 2 or carrier 3, it would have saved us $200,000, $300,000, $1 million type of thing. And that's the beauty of it, is the granularity goes much further beyond, such and such carrier has a 43% discount in our market.
Oh,
that just doesn't tell us anything.
43% off of what?
Yeah, exactly.
Right. I could name a discount off of anything if you let me pick, a fictitious starting price. 99% off. Oh, that's crazy.
Yeah,
So,
it's a game.
oh, it's a dirty game, for sure. But what I'm hearing though is, in your example before, I think you said it eloquently. Like, if you have three providers with equal quality scores that are equidistant in the same market, and there's a price disparity of one of them is a third the cost or half the cost of what the others are, that that calculus is pretty simple, right? I think anyone can figure
Yep.
that math out. And if you, as an
Yep.
employer, can design a plan and construct your plan summary document, summary plan document, and your SBCs to reflect that an employee, a member that is making that choice, is going to benefit with $0 out of pocket costs. I think that's where the gold is right there.
Absolutely, absolutely, and I think that's again, and I talked a little bit about the granularity. That's really where this data shines, is because it is down to the individual provider level. It's down to the individual procedure, and you can even see, like, if this was billed at a level 4 versus a level 3, like, that price is going to vary. And so that granularity, when you look at it, just brings a ton of opportunity for a benefits leader to make some strategic decisions that you can't make when we're saying, okay, they have a 43% discount. It's like, okay, great. Like, we're just gonna expect something good. So
yeah, I don't think any CFO that's listening, I don't think that little tidbit is lost on them. It's like, no. I'm a numbers guy. I'm a numbers gal, right?
Yeah.
Like, what is the starting point of this discount? You have a personal story to share. How'd you get into this racket?
Yeah, so I graduated college. I grew up playing basketball, and that was just like my whole personality. And then you graduate college, you're like, okay, what am I going to do? And
are you super tall? We can't see. You're sitting down. How tall are you?
6'2", not super tall.
All right.
So,
no, but that's all right. I mean, for a high school, college player, you're in the range.
Yeah. And so I tore my ACL like 2 months before graduating, and you're approaching a lot of milestones in life, and so I had never really leveraged the healthcare system, like, at all. That just wasn't something that I had, like, needed to do. So I scheduled the surgery. I got my surgeon based off of a recommendation from a friend. He had done a professional athlete's surgery, and so I was like, this is going to be great. And that's just how I chose him. He was in network. I even got a pre-auth letter from my insurance, but I didn't read it in the fine print, and I'll talk about that here in a second. We go in to have the surgery. I'm expecting, maybe, I don't even know why I'm expecting, but I'm expecting maybe $4,000. And 3 weeks later, I got a bill for 27 grand. And
nice.
I was shocked, to say the least. And then as I looked at the fine print, it was all facility fees. So what had happened, and this is pre, like, No Surprises Act, this is pre-CAA, all of this legislation.
Right.
I was surprise billed because the facility that this surgeon performed surgeries at was out of network, but the surgeon was in network. So that pre-auth letter that I had gotten was, hey, your surgeon is in network, but it said nothing about the facility, and I didn't get any pre-auth letter on the facility. So I fought it for 3 years. I learned a lot about the healthcare system. I ended up getting my own, like, special customer service number with both the carrier and the facility, basically trying to negotiate this down. After 3 years, we settled on like $2,600, and it was good. And I learned a lot, but that was like the moment where I was like, I'm going to go work in healthcare because this is so messed up. This shouldn't exist. And thankfully, the No Surprises Act has come out, and hopefully that's a thing of the past where people are completely shocked and floored by, surprise bill. But that was my experience. I've unfortunately learned that that's not a unique experience in America, though. It felt like it was at the time, but it's not a unique experience. I think everybody has a poor experience at some point with the healthcare system. And like I said, a lot of it has to do with the business side and the billing side, less about the actual care received.
Oh, 100%. And you're right. You're not alone. So 100 million people are carrying medical debt out there. That's practically a third of the country, a quarter of the country, which is insane. But that is the state of affairs, the current state of affairs. I'd also say that you're someone that you're a smart guy. You were willing to roll up your sleeves and jump in and not turn over and pay that bill, which I think many people do because they either don't have the intellectual capacity or the support system or the wherewithal to know that they can fight and push back. So, that you were able to get that knocked down to maybe a tenth or less of what they originally billed is kudos to you. And for folks that might be in that predicament that are listening, there's a great book out there called Never Pay the First Bill. And it was written by Marshall Allen, who was an industry insider, traveled in a lot of the same circles that we do. And he unfortunately died prematurely, I believe it was last year, in spring of last year. And we lost the great leader in this movement. But for folks that are being faced with collection letters and they're just they're getting these surprise bills that are just coming out of nowhere, because even though the legislation is out there, these bills still do show up, and they show up kind of for reasons like you mentioned, like you have a member or an employee that is a patient and they're getting care and they do their part and they check and the physician or the surgeon is in network, but the facility is not in network. That's an out-of-network charge. These bills are still showing up. There's something you could do about it. So Never Pay the First Bill by Marshall Allen. You can pick it up on Amazon. And he's a crusader for the underdog. So he maps out exactly and specifically what you should do to fight back and either get those charges greatly reduced or get them, just kind of nullified completely. And so sorry that you went through that, but it gave you an insider's perspective and, kind of fueled your passion to jump into the industry. So everything happens for a reason, I guess.
Yeah, I'm very grateful for it in hindsight. But I mean, those 3 years were filled with a lot of like anxiety, stress. And you're just worried about I'm up against a big system and I don't know how it works. And, I don't know what's going to shake out. And it's not like they can go back into my knee and take it out and say like, okay, like we're going to take that back. Like the surgery was done. I'm grateful for the experience, but it has lit a fire in me personally. And I know I'm not the only one that, the system is so complex. And I think one of the challenges, and you alluded to it earlier in your comments which is there's misaligned incentives kind of everywhere you look in healthcare. And I think the way that we truly fix healthcare is everybody has to come to the table and be collaborative and talk about these solutions together. Employers, payers, providers, they've got to come together, because otherwise, with the misaligned incentives, it's just going to be hard, and there's always going to be some area of healthcare that's going to be too complex, and we won't be able to solve it. And I think that's ultimately how we solve it: is everybody has to come to the table and be collaborative together. And we're starting to see that with this data, which is pretty exciting. But I think again, employers can't keep fronting 8 to 10%, increases, and so we've got to act quick.
No, and the other piece of this is with the passage of the CAA, we're now starting to see lawsuits pop up because employers are held to the same level of scrutiny managing their health plan as they are their 401k or their retirement offering. And so they have a fiduciary obligation to their employees and members to spend plan dollars wisely. And, for most business professionals that are in the C-suite, how do you begin doing that? Well, I don't think the best way to do that is to enlist your broker who's managing this, maybe in your best interest, maybe not, but you have to inspect what you expect. And what I'm hearing, Shay, is that with Turquoise, you do have a great tool to do just that. Now, is that going to be the end of your, fiduciary compliance? Of course not. But I think if you have a process for recording, here's what we did to ensure that we are spending plan dollars wisely, and part of our process is the Turquoise Health solution. I would think that would go a long way if you do come under scrutiny by the DOL, or God forbid there's a lawsuit. You can at least go back and show that you have a process, and you're not simply just kind of taking the insurance carrier at face value. You're checking some additional boxes. You're going above and beyond. That in and of itself, I would think, could be a sort of insurance policy for an employer.
Yeah, absolutely. You hit the nail on the head. That's what employers are looking to, companies like Turquoise that leverage price transparency data to do, which is we need to fulfill our fiduciary obligation. Those lawsuits, I was actually just reading one before I came on this podcast. There's some updates to one that's happening in Michigan. And I think that, candidly, some benefit leaders are a little nervous about, like, is that going to be us, right? Or like, what is this going to shake out? And this data really helps, again, kind of provide another piece of validation. To your point, it's not going to fix things overnight because we have to leverage the data, right? But just looking at it will give you a level set on, we're fulfilling our fiduciary duty. We're doing those checks and balances. And then now we're going to leverage it to kind of optimize this piece of our network or optimize this part of our member experience.
Yeah, no, it's super important. And I've had the privilege of interviewing, several attorneys, including Julie Selesnik and Day Lee, who specializes in the pharmacy space, and Adam Russo. And what most C-suite professionals, I don't think, realize is that under the law, they're personally liable as well. So their organization is not only on the hook, they are on the hook personally. And so there's the potential for them to be named in a lawsuit. And if that's not an incentive to inspect what you expect, take a look under the covers, and make sure that you're doing everything properly, I don't know what is. So I think we're just starting to see the tip of the iceberg with respect to the litigation. I think the lawsuits are coming. And it'd be wise, I think, to get ahead of it if you're an employer out there listening. So, listen, you shared a ton with us today. I appreciate your time. How do folks give us the website again, and how do folks get a hold of you if they need you?
Yeah. Turquoise.health is our website. You can go and search for care. You don't even need an account. You can just go search for care if you're curious about, like, I have an X-ray coming up or an MRI. And then feel free to connect with me on LinkedIn. I'm pretty active on LinkedIn. If you look up Shay Forbes, try to produce a decent amount of content on price transparency, the legislative updates. In the next week or so, I'm not sure when this will air, but in the next week or so, we'll actually have some exciting legislative updates that are due by the 26th of May. And so hopefully we'll have some more things to share around price transparency legislation there. So I'd say LinkedIn and then our website, turquoise.health.
Awesome. Well, hey, Shay, thank you so much for being with us today. We really appreciate it. Folks, until next time, love always. Take care.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.